Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 196 of our Pharmacotherapy MCQ series, which majors in cardiology. And the next question reads, which of the following physiological conditions best describes the drug-induced cardiovascular disease caused by thalidomide? Is it A. QT prolongation, or B. heart failure, or C. hypertension, or is it D. bradycardia? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. bradycardia. Thalidomide causes bradycardia at a rate of 25% to 50%. That makes answer D correct. If therapy cannot be discontinued, a permanent pacemaker may be necessary. Thalidomide is not associated with the development of hypertension, heart failure, or QT prolongation. That makes answers A to C incorrect. Please advance to the next question. And the next question reads, JKL, a middle-aged male patient is admitted to your hospital with respiratory failure requiring mechanical ventilation. He is admitted to the medical intensive care unit where he eventually develops ICU delirium and is initiated on haloperidol 5 mg IV every 4 hours PRN and quetiapine 50 mg at night. Over the past 24 hours, he has required 20 mg of IV haloperidol to maintain calmness. The next morning, his ECG reveals normal sinus rhythm with a corrected QT interval of 560 milliseconds. His primary nurse notices a 4-beat run of polymorphic ventricular tachycardia, torsade de Poor, abbreviated as TD/P, on the telemetry monitor, which converts spontaneously back to sinus bradycardia at a rate of 42 beats per minute. The critical care team discontinues haloperidol and quetiapine, and JKL is hemodynamically stable. So my question to you is, which of the following would be the most appropriate treatment for JKL after discontinuing the offending agent? Would it be A. administer magnesium 2 grams IV over 15 minutes and begin an isoproterenol infusion, or B. administer magnesium 2 grams IV over 15 minutes and begin an amiodarone infusion, or C. administer magnesium 2 grams IV over 15 minutes, or would it be D. defibrillate this patient? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Administer magnesium 2 grams IV over 15 minutes and begin an isoproterenol infusion. Discontinuing the offending agent or agents is the first step in managing torsade de poor, abbreviated as TDP, but additional management is required. In patients who are unstable or refractory to therapy, defibrillation would be appropriate. However, because this patient is hemodynamically stable and no treatment has been given, defibrillation would not be indicated at this point. That makes answer D incorrect. Magnesium is an appropriate treatment for hemodynamically stable TDP. In this case, because the TDP was accompanied by bradycardia, an isoprotronol infusion should also be initiated to increase heart rate. That makes answer A correct, and answer C incorrect. Amiodarone is not used for TDP. That makes answer B incorrect. Please progress to the next question. And the next question reads, TWA, a 45-year-old male patient presents to your accident and emergency department with chest pain, nausea, diaphoresis, and weakness. He has a past medical history significant for type 2 diabetes mellitus, hypertension, hyperlipidemia, and a recent right knee meniscus tear. His current medications include atorvastatin 20 mg at night, dapagliflozin co-formulated with metformin 10 mg/ 1000 mg per day, diclofenac 75 mg orally twice daily, lisinopril 20 mg orally once daily, and dulaglutide 0.75 mg injection once weekly. His ECG is notable for inferior ST segment elevations. A drug-eluting stent is placed in the right coronary artery by your interventional cardiologist. TWA is ready for hospital discharge, and diclofenac therapy is discontinued. So my question to you is, which of the medications listed below would be the most appropriate treatment for TWA's knee pain? Would it be A. acetaminophen paracetamol, or B. naproxen, or C. meloxicam, or would it be D. celecoxib? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. acetaminophen paracetamol. The American Heart Association stepwise approach to managing musculoskeletal pain in patients with cardiovascular CV disease or risk of CV disease tries to minimize exposure to nonsteroidal anti-inflammatory drugs NSAIDs with cyclooxygenase 2 (COX2) selectivity. Changing from diclofenac, an agent with high COX2 selectivity, to another agent with COX2 selectivity would be inappropriate unless all other options had been exhausted. Because celecoxib is a COX2 selective inhibitor and meloxicam has some COX2 selectivity, they should also be avoided in this patient. That makes answers D and C incorrect. Although naproxen is a non-COX2 selective NSAID, it should be reserved for use after other agents have been tried and have failed. That makes answer B incorrect. In this patient with known CV disease, the most appropriate agent would be paracetamol, acetaminophen. That makes answer A correct. Other potential agents include tramadol and short-term narcotic analgesics with caution, given abuse potential. Please proceed to the next question. And the next question reads, a consultant cardiologist contacts you with a query regarding a patient, MOW, with a known heparin allergy according to the chart from an admission 14 days ago. Back then, the patient received prolonged therapy with unfractionated heparin pending cardiovascular surgery. His pertinent laboratory values from that admission show a positive enzyme-linked immunosorbent assay, abbreviated as ELISA test, optical density 0.57, and a negative serotonin release assay. MOW presents to the cardiology clinic today. His chief complaint is a chest pain, and the physician seeks your input in evaluating these test results above to determine whether MOW has a diagnosis of heparin-induced thrombocytopenia, abbreviated as HIT. So my question to you is, which of the following would be the most appropriate response to the physician's query? Would it be A. A 40S score is needed to make the diagnosis, or B. Additional laboratory testing is needed to make the diagnosis, or C. The patient is HIT negative because of the negative serotonin release assay alone, or would it be D. The patient is HIT positive because of the positive ELISA test alone? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. The patient is HIT negative because of the negative serotonin release assay alone. A HIT diagnosis involves a combination of clinical and laboratory assessment. In this case, with available laboratory values, a 40S score is not needed because this scoring system determines the need for laboratory testing and alternative anticoagulant treatment. That makes answer A incorrect. The ELISA test is available in most hospital laboratories and is useful to rule out the diagnosis of HIT because of its high degree of sensitivity, which is 99%. However, a positive result should prompt additional testing with a serotonin release assay for confirmation because the ELISA test has low specificity. That makes answer D incorrect. A serotonin release assay is usually considered the gold standard because of both its high sensitivity and its high specificity. A negative serotonin release assay after a positive ELISA test result confirms the patient does not have HIT. That makes answer C correct. Additional antigen and functional assays are available but are not needed in this case because the serotonin release assay results are provided. That makes answer B incorrect. Please proceed to the next question. And the next question reads, which of the following values best depicts the relative risk of death at 1 year in the enalapril compared with the placebo groups according to the consensus trial? Is it A. 0.69, or B. 0.52, or C. 0.59, or is it D. 0.16? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. 0.69. The ability to calculate point estimates of risk is essential in interpreting and disseminating the literature. According to the data provided, the relative risk at 1 year would be 0.69, making answer A correct. Answer D, 0.16, is the absolute risk at 1 year, making this answer incorrect. Answer C, 0.59, is the relative risk at 6 months, making this answer incorrect. Answer A, 0.52, is the odds ratio at 1 year. I would recommend you briefly read about this trial. Please advance to the next question. And the next question reads, which of the following values best depicts the number needed to treat to prevent 1 death at 6 months with enalapril compared with placebo according to the consensus trial? Is it A, 22, or B, 15, or C, 10, or is it D, 6? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D, 6. The ability to calculate a number needed to treat is extremely important, not only for interpreting the literature but also as a tool for patient education to demonstrate the benefits of pharmacotherapy. The number needed to treat can easily be calculated using the following formula: 1 divided by the absolute risk, e.g., 1 divided by 0.43 minus 0.26, which is equal to 5.55, which can be rounded off to 6. Thus, answer D is correct and answers A to C are incorrect. Please advance to the next question. And the next question reads, you currently belong to the Institutional Quality Improvement Committee to develop patient educational tools to improve patient awareness of their heart failure (HF) symptoms and when to seek medical care. So my question to you is, which of the following would be most appropriate and cost-effective to give to patients at the time of hospital discharge to address this issue? Would it be A, Get with the Guidelines HF clinical tools, or B, Micromedex care notes for each medication, or C, AHRQ addressing HF symptoms, or would it be D, Minnesota Living with Heart Failure questionnaire? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, AHRQ addressing HF symptoms. As a cardiovascular pharmacist, you may potentially be expected to serve on quality improvement committees within your health system as well as to make suggestions regarding potential resources for patient education. In this case, the AHRQ addressing HF symptoms is the best patient educational tool because it is free, is available on the internet, and provides patient awareness of their HF symptoms as they pertain to seeking medical attention using a color-coded, zone approach. Patients can decide when to seek medical care on the basis of their HF symptoms, making answer C correct. The Minnesota Living with Heart Failure questionnaire captures a patient's quality of life and is more informative as such than as an educational tool, making answer D incorrect. Although Micromedex care notes, that is answer B, provide excellent patient information for each of the patient's HF medications, these educational materials do not always specifically address when to access medical care. In addition, to access these materials, a health system must have a license for Micromedex, which can be expensive, making answer B incorrect. Answer A is incorrect because Get with the Guidelines is a registry for hospitals to document and benchmark their improvements in guideline-directed care. However, although this resource from the American Heart Association does provide some patient educational materials, it does not specifically address assessment of symptoms and when to access medical care, making answer A incorrect. Please progress to the next question. And the next question reads, which of the following patients is the best candidate for initiation of ivabradine? Is it A, an 80-year-old with NYHA Class II heart failure with an LVEF of 20% with a heart rate of 80 beats per minute receiving enalapril 10 mg orally twice daily, metoprolol succinate 200 mg orally once daily, and spironolactone 25 mg orally once daily, or B, a 55-year-old with NYHA2 heart failure with an LVEF of 35% with a a heart rate of 65 beats per minute receiving maximal guideline-directed medical therapy, or C. A 75-year-old with NYHA functional class 4 heart failure with an LVEF of 20% with a heart rate of 110 beats per minute currently receiving milrinone, or would it be D. A 65-year-old with New York Heart Association NYHA functional class 1 heart failure HF with a left ventricular ejection fraction LVEF 55% with a heart rate of 73 beats per minute taking enalapril 10 mg orally twice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. An 80-year-old with NYHA class 2 heart failure with an LVEF of 20% with a heart rate of 80 beats per minute receiving enalapril 10 mg orally twice daily, metoprolol succinate 200 mg orally once daily, and spironolactone 25 mg orally once daily. According to data from the SHIFT trial, the ideal candidate for ivabradine would be a patient with HF with reduced ejection fraction with NYHA functional classes 2 and 3 and a heart rate greater than 70 beats per minute who is taking the maximally tolerated dose of a beta blocker and is in normal sinus rhythm. Answer A is correct because this patient matches each of these criteria. Answer D is incorrect because this patient has NYHA class 1 HF and HF with preserved ejection fraction. Answer C is incorrect because the patient has a heart rate of 110 beats per minute, most likely because of milrinone, and has NYHA class 4 HF. Answer B is incorrect because the patient's heart rate is already less than 70 beats per minute. Please advance to the next question. And the next question reads, NWT, a male patient presents to your cardiac clinic. He has a chief complaint of symptomatic New York Heart Association NYHA functional class 3 heart failure HF with a left ventricular ejection fraction less than 30% and newly diagnosed type 2 diabetes mellitus. His pertinent labs include an estimated glomerular filtration rate of 46 ml per minute per 1.73 meters squared. He has a past medical history significant for ST segment elevation myocardial infarction, which occurred 1 year ago, hypertension and hyperlipidemia. Despite taking maximal doses of metformin, NWT, SHB, A1C is currently 7.1%. So my question to you is, which of the antihyperglycemic medications listed below would be most appropriate to reduce NWT's cardiovascular, CV, morbidity and mortality? Would it be A. rosiglitazone, or B. saxagliptin, or C. empagliflozin, or would it be D. alogliptin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. empagliflozin. Concomitant type 2 diabetes occurs in about 35% of patients with HF with reduced ejection fraction. Evidence continues to emerge that treatment of a patient's diabetes can also affect the patient's HF outcomes. In the EMPA-REG trial, empagliflozin reduced HF admission or CV death by 34% and HF admission by 35% in patients with type 2 diabetes and underlying CV disease. Thus, empagliflozin would be a good choice in this patient, making answer C correct. A U.S. Food and Drug Administration (FDA) safety review found that type 2 diabetes medications containing alogliptin and saxagliptin may increase the risk of HF hospitalizations, particularly in patients who already have heart or kidney disease, making answers D and B incorrect. As a result, the FDA has added new warnings to the drug labels regarding this safety issue. The American Diabetes Association recommends against the use of thiazolidinedione in patients with symptomatic HF because of the increased risk of pulmonary and peripheral edema. That makes answer A incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 197.